Uh, Good evening, Lubna. Uh,
Hello.
are we audible? Yes.
Yes, I can hear you.
Okay. With me there is Dr. VP Singh, who is chairperson, and I'm Dr. Vinetosh Mishra, your coordinator for the session. So, how are you?
I'm doing well, Dr. Singh and Dr. Mishra. Nice to meet you both.
Thanks. So we will. I will give mic to Dr. VP Singh to introduce you, and then we will continue with the session.
Okay, thank you.
Now talk will be by Lubna Mirza from the USA, and a very interesting topic is the cardiovascular manifestation of the parathyroid disorder. Though it is a rare problems, but it is a more common. So we will heard the talk on the um, Mirza by the cardiovascular manifestation of the parathyroid disorder. Welcome, madam. We can start.
Thank you. Thank you. My name is Lubna Mirza. I'm an endocrinologist in Norman, Oklahoma. And today I will be talking about cardiovascular manifestations of parathyroid disorders. At first, I thought about talking about hypothyroidism and heart disease, but I saw that some other people were speaking about the same topic, so I thought I will pick something different. And I'm going to try to share the slideshow. Let's see if it works. It tells me my screen sharing is paused. For some reason, it doesn't allow the slideshow views. Is it okay if I just present in the
Allow
presenter's mode?
it. Rights are shared, Dr. Mirza. For sharing this, can please press F5 once. Let's see what happens.
F5. Okay.
Okay.
You want to enable dictation. So say yes.
Yes.
Okay. All right. So
Share
let's
slide.
start our discussion then.
No, share is restricted. Lower panel, there will be, yeah. Just click there.
Yes, I know whenever I start sharing the screen, it says your screen sharing is disabled. For some reason, there is some
Do
error.
do one
I know
thing.
how to share.
Do one thing.
Mhm.
Close the presentation PowerPoint and start it again.
Okay.
Now start it.
Okay. Okay. I am sharing the screen. It
Yeah.
says your screen sharing is paused. There is some error. I know how to do it, but it just doesn't work. Okay.
Continue without slide slow. Uh,
Okay.
okay.
Let's do that.
Yeah.
Okay. So
No,
this
no,
is the
not
outline
like
for my
that.
presentation.
As you were sharing earlier, no, it was not in presentation mode, but you can scroll down the PowerPoint as it was there, no? Or
Yes.
do one thing, share your screen, uh,
Mm-hmm.
and on that you open this PowerPoint presentation. That will also work.
Okay.
Okay?
Because it's in a Google Doc, maybe I should download it. That way
Ah,
works too.
yes, yes, yes,
I
yes.
see.
You
Okay,
download it.
let's do that. Mm-hmm.
Download it.
Yes, it's opening. Okay, yes. So I downloaded it. And now I will share my screen again. And this time it should work.
Yeah, it will work. Hopefully.
Okay. All right, this is so much better. Okay, so this is the outline for my presentation. We will do the introduction. I will discuss a couple of cases. These are my patients that I have seen. Pathophysiology, cardiovascular manifestations of primary hyperparathyroidism. We will review literature and how do we make the diagnosis and how do we treat these people. So the parathyroid glands are responsible for maintaining the crucial function of calcium homeostasis, as we know. There are 4 to 6 parathyroid glands. Some people have 2 pairs and some people have 3 pairs. And they're approximately close to the thyroid gland. That's why it creates a lot of confusion in many of our patients. When they come in to be seen for parathyroid, they think they're being seen for thyroid. They weigh approximately 40 grams each. The secretion of parathyroid is modulated by serum calcium, phosphorus, and vitamin D. A brief history. The parathyroid glands were first discovered in the Indian rhinoceros by Richard Owen in 1850. He saw a cadaver of a rhinoceros in a museum and he noticed these yellow stuck-on glands on a thyroid, and that's where it was first seen. But the glands were first discovered in humans by a medical student. He was a Swedish medical student and he discovered them in 1880. Parathyroid was one of the last major organs to be recognized in humans. There are a couple of cases I'm going to discuss with you. This is the first case. This is a 58-year-old woman. She presented with hypercalcemia going on for about 3 years. She had lack of energy, depression, memory issues. She did not have any history of kidney stones or fractures. Her calcium, as we can see, is quite high at 11.1 milligram per deciliter. Her parathyroid hormone level is also elevated at 106, so both are increased, which is biochemical evidence for primary hyperpara. Her vitamin D level is mildly decreased to 26. As we know, normal range for vitamin D is anywhere from 30 to 100 nanograms per ml. Her 24-hour urine calcium is high at 561 milligrams. Her ionized calcium was also increased at 6.1. Her DEXA bone density exam showed she had osteoporosis with a worst T-score of minus 2.7 in her lumbar spine. This is the second case. It's a 41-year-old man. He was referred to us for high calcium on routine labs. His serum calcium came back at 10.7, IPTH is 93, ionized calcium 1.4. It's millimole. 24-hour urine calcium was 240, creatinine 1640, so adequate collection. Alkaline phosphatase was high, 131. Phosphorus 2.8, 25 hydroxy vitamin D level is only 13 nanograms per ml. His DEXA bone density exam was normal. We will come back to these cases at the end of this presentation to see what you would like to do for them. For the first case, I don't think anybody will question if we refer her for surgery, but what about the second one? So this is normal system. As we know, we have 2 to 3 pairs of parathyroid glands right behind the thyroid mostly. When our serum calcium is decreased, the normal serum calcium level is from 8.5 to about 10.2 or 10.3 milligrams per deciliter, depending on your reference lab. When our calcium level is decreased, it stimulates the PTH release, which tries to increase our serum calcium level by increasing bone resorption, by increasing the reabsorption of calcium from the kidneys, and by increasing gut absorption of calcium with the conversion of vitamin D from 25 hydroxy vitamin D to 125 dihydroxy vitamin D. This is the active form of vitamin D, which the conversion happens in the kidneys, and that helps the calcium absorption from the gut. The end result of all of this effort is to increase our calcium level. This is the histology of our parathyroid glands. We have chief or principal cells and oxiphyll cells. The chief or principal cells produce parathyroid hormone, but the exact function of oxiphyll cells is not known. They are very rich in mitochondria that hold on to the dye longer, sesame B dye longer. That's how we localize the parathyroid glands. Parathyroid hormone is an 84 amino acid peptide. It is derived from pre-pro-PTH to pro-PTH to PTH. by trypsin-like protease, and they are packaged in these secretory granules and they're released when we need them. The molecular weight for PTH is 9500 delta. It is recognized by PTH1 receptor and then acts on the target organs to affect its effects. 70% of it is metabolized by the liver and 20% by the kidneys. The half-life is very short. The half-life of parathyroid hormone is very short, about 2 to 4 minutes, and that's why after surgeons have removed the parathyroid adenoma, in only 5 to 10 minutes, they can check parathyroid hormone levels, and if it has dropped more than 50%, then they know they got the tumor, or they will keep looking. There are calcium sensing receptors, which are present in our parathyroids, thyroid C cells, and also in the kidneys. When calcium level is high, it will activate the calcium sensing receptor, which will stop the production of PTH. But if our calcium is low, that will inactivate the calcium sensing receptor, and that results in the increased production of PTH. And as we discussed earlier, PTH will try to increase our serum calcium level because calcium must stay in that normal range, 8.5 to 10, for basically all cells in our body need calcium to stay in the normal range to function. Primary hyperparathyroidism is the most common cause of hypercalcemia in outpatient clinical setting. And as we know, if patients are found to have hypercalcemia in the hospital, they are more likely to have malignancies. Primary hyperpara prevalence ranges from 1 to 4 per 1,000. More females are affected, 2 to 1 to 3 to 1 ratio. Most of the time, about 85% of the time, primary hyperparathyroidism happens because of a single gland adenoma. Incidence increases with age, and postmenopausal women have an incidence 5% higher than the general population. Causes of primary hyperparathyroidism, the exact cause is not known, but ionizing radiation may be associated. There are some studies that show irradiation for acne can increase risk. Survivors of atomic bomb had 4-fold increase. And then people who have received external beam radiotherapy for benign disease before their 16th birthday. So that childhood exposure is very important. And the present doses of I-131 for thyrotoxicosis do not increase the incidence of primary hyperpara because for Graves' disease, we don't use a lot of high dose. But if somebody has had cancer, thyroid cancer, and they have received higher dosage of radioactive iodine, then their risk of primary hyperpara can be increased. And in fact, I have seen that in one of my own patients. There are some rare familial disorders that are associated with primary hyperparathyroidism, such as multiple endocrine neoplasia type 1 and MEN2A, familial hypocalciuric hypercalcemia, very, very important to distinguish from primary hyperpara since it's a benign condition. It does not require surgery. If we send these patients to surgery, after surgery, the calcium will stay high and it's not going to benefit them. Jaw tumor syndrome, and then familial isolated hyperparathyroidism. So it brings us back to our topic. Since we are in the cardiovascular conference today, we are going to talk about how parathyroid disease affects our cardiovascular system. So there are two ways parathyroid hormone can affect our cardiovascular system. There are direct actions of PTH on the heart, and it can also work through the calcium. So alteration of calcium homeostasis, both hypercalcemia or hypocalcemia is a problem. And in endocrinology, we know too much or too little of any hormone can be an issue. Balance is very, very important. Cardiovascular complications of parathyroid disorders include hypertension, arrhythmias, heart failure, calcification of blood vessels and valves. Parathyroid disease has important implications for mortality and morbidity stemming from cardiovascular disorders. How does PTH affect on the cardiovascular system? So we will look at the molecular actions. PTH, parathyroid hormone, binds to the target organ PTH1 receptor, which is a G protein coupled receptor with 7 transmembrane domains, as you can see those green bars there. And depending on the target organ, Subsequent activation of this receptor will involve either protein kinase A or protein kinase C pathway. The result of parathyroid hormone stimulation is left ventricular hypertrophy. As we know, left ventricular hypertrophy is an important predictor of cardiac morbidity and mortality. It is driven by the direct effects of PTH on cardiac PTH1 receptor. It causes increased intracellular calcium and upregulation of protein kinase C. And this protein kinase C will activate cardiac myocytes hypertrophy. And on the right, you are seeing this PTH1 receptor. There are two types of calcium channels in cardiomyocytes, the L-type and the T-type. The L-type calcium channels are very important. They are responsible for the excitation, contraction, coupling of skeletal, smooth, and cardiac muscles. In the right upper corner, you are seeing the L-type calcium channel. It is consistent of this protein that has 5 ligands. Aldosterone secretion in the zona glomerulosa is also mediated by the L-type channel. Neurohormones, neurotransmitters in the neurons. L-type calcium channels, they also play a very important role in gene expression, messenger RNA stability, neuronal survival, ischemic-induced axonal injury, synaptic efficacy, and both activation and deactivation of other ion channels. PTH will act on the L-type of calcium channel. It increases the entry of calcium, increases intracellular calcium concentration, promotes apoptosis of cardiomyocytes, and it will induce oxidative stress and necrotic cell death by promoting mitochondrial oxygen calcium excess, which is in the long run exacerbates myocardial fibrosis. As long as the parathyroid hormone level is normal, our heart will continue to function normally, but all of these deleterious effects on the heart happen if we have too much of parathyroid hormone. There are L-type calcium channel blocker. Drug use will depend on their affinity, whether do they have affinity for the heart or they have affinity for the blood vessels. Like verapamil will work on the heart, and nifedipines will be more effective on blood vessels. They will slow the heart rate and lower blood pressure. PTH in normal amounts is important, and it has normal physiologic effects on our vasculature. In the right upper corner, you are seeing a normal blood vessel wall. On the right side, you are seeing the nice endothelial lining. And then we have the smooth muscle cell lining with internal elastic membrane and the external elastic membrane. These smooth muscles have the PTH receptors. So the PTH increases cyclic AMP production in vascular smooth muscle cells. It leads to vasodilatation through decrease in calcium entry into the cells. And PTH receptors are also present on the vascular endothelial cells, where it helps them produce nitric oxide. We know the laughing gas is important, very important in vasodilatation and relaxation. Increased activity of both protein kinase A and protein kinase C pathways are important here. And PTH will also prevent the progression of vascular calcification by inhibiting signals. If we have too much of parathyroid hormone, that will lead to atherosclerosis, and many clinical studies have demonstrated. It also increases calcification. Not only the parathyroid hormone, but phosphate, calcium, vitamin D, and other minerals will affect the vascular system in clinical settings. Primary hyperparathyroidism is also related to calcific disease. On the right-hand side, you're seeing a picture, which is also known as porcelain heart. There is higher incidence of calcific heart disease in patients who have primary hyperparathyroidism. Reports show up to 78% involvement of myocardium or valves. Calcium deposition has been identified in valvular annuli and cusps, coronary artery media and intima, individual myocardial fibers, and interventricular septum. And primary hyperparathyroidism can present with valvular stenosis in younger patients. So if we see a younger person who has valvular stenosis, we should think of primary hyperpara. And I hope that they go through some basic lab, CMP, CBC, so we can pick up that hypercalcemia on their CMP. This is a prospective study by Stefanelli et al. They looked at 123 patients who had primary hyperparathyroidism, and they saw that 46% patients had aortic valvular calcifications, 39% had mitral calcifications, and 74% had myocardial deposits. After having their parathyroidectomy, they were followed after 12 months and then 41 months later, and they saw that there was no disease progression. So even if the disease didn't reverse, but we can see that at least it did not progress further. This is an interesting point that I also learned while working on this presentation, that PTH works with the RAS system, and there is bidirectional relationship. When we have increased levels of parathyroid hormone, it leads to the activation of RAS, which increases aldosterone levels. And the higher aldosterone concentrations, on the other hand, are associated with higher serum PTH. And in some observational studies, they saw that the use of RAS inhibitors, such as angiotensin converting enzyme inhibitor or angiotensin receptor blockers, were associated with lower PTH levels. And it happens because the zona glomerulosa cells have PTH1 receptors. And if we remember the histology, the adrenal glands are very complex structures. They have cortex, and medulla cortex has 3 different layers producing aldosterone, cortisol, and DHEA. The medulla produces catecholamines. So the effect of eplerenone in patients with primary hyperparathyroidism is underway, and I am really looking forward to seeing the results, which is very, very interesting. We prefer to send our primary hyperparathyroid patients to surgery, but if they're not a surgical candidate, perhaps this medication will be helpful for these patients. Incidence of hypertension in primary hyperpara, we are aware that there is increased prevalence of hypertension in patients who have primary hyperparathyroidism, and their blood pressure improves. I have seen that in many of my patients who go through parathyroidectomy, that after having the tumor removed, when they come back, their blood pressure gets better. And this study is a population health survey done in 1995. They saw the relationship between low calcium intake, parathyroid hormone, and blood pressure by R. Jord et al. And they saw that serum PTH was measured in over 1,000 subjects. Their ages were 30 to 79. And in women, they did not see a difference in men, but in women, they did notice that high PTH levels were associated with markedly increased blood pressure. And some studies have also seen that in Black patients. Hypo or hypercalcemia both can cause ECG changes.
Dr. Mirza, sorry to interrupt you.
Yes?
Please
Yes.
conclude the session in 5 minutes if possible.
Oh, okay, absolutely.
Okay, thanks.
Okay. So we have, these are some of the proposed mechanisms for cardiac disease we just went through. This is just a summary slide for them. And I will send you my slides so you can share them with the audience if you like. This was an interesting study I wanted to include because I was curious whether the effect of parathyroid hormone on our heart is only dependent on calcium or there is direct effect. So this study was done in 2010, a basic science study by Jeong et al. And they looked at these mice. They gave these mice left ventricular hypertrophy with procedures. And then these mice were treated with saline or PTH for 2 weeks. And after that, these mice were sacrificed and their tissue was examined. And you can see on the right-hand side, the PTH-treated mice had worse hypertrophy. They had angiogenesis and fibrosis. So there is some direct effect of PTH. This study is very important. This was published in Annals of Surgery 2023, quite recent. They compared the incidence of adverse cardiovascular events in older adults with primary hyperpara treated with parathyroidectomy versus non-operative management. And you can see that it's quite large study, and they saw positive results 1 year later and 10 years later, parathyroidectomy was associated with better MACE outcomes. So in this large population-based cohort study, parathyroidectomy was associated with a lower long-term incidence of adverse cardiovascular outcomes when compared with non-operative management for older adults with primary hyperparathyroidism, which is relevant to surgical decision-making for patients with a long life expectancy. Since we are out of time, I will just quickly mention that, of course, hyperparathyroidism affects our kidneys negatively, causes psychiatric problems, GI issues, bone manifestations, other manifestations. Patients may be asymptomatic if they are being seen in places close to the hospital, but I do still see some patients who are from small towns, or they don't like to go see doctors. You can see the severe disease in these patients. Diagnosis is based on biochemical. So first we have to prove that they have primary hyperparathyroidism by high calcium, high PTH. They have to have both things high, and then distinguish them from the familial hypocalciuric hypercalcemia, and then surgery is preferred. I would recommend surgery to both of the patients that are presented in the beginning of my talk because of all of these cardiovascular benefits. And we know we check CMP, ionized calcium, PTH, PTHRP. I always check a PTHRP, 24-hour urine calcium, both 125D and 25D in these people. After surgery, and of course, imaging studies are very important. We used to do exploratory parathyroidectomy, but now with the advent of nuclear system EB scans and ultrasound studies, it has become easier for us to localize their tumor before the surgeon goes in. Parathyroidectomy is the definitive therapy. Surgical techniques are open parathyroidectomy or minimally invasive procedure, and parathyroidectomy indications are different for symptomatic and asymptomatic patients. But considering all the benefits of parathyroidectomy, I have seen that if I just follow them, eventually they just get worse and worse. So it's just a matter of time. They eventually need surgery. So sooner the better. The guidelines have changed over the years, and now the Endocrine Surgery Society recommends surgery for these patients. After surgery, they do better. Their electrolytes improve, their PTH falls, their bones get better. One of my patients had such a remarkable improvement in her bone density that whoever was reading, the radiologist, did not even believe. He thought maybe it was an error. They have improved cardiac outcomes, improved renal outcomes. Medical management, if we cannot do surgery, only then we will reach for medical management, but surgery is preferred. Okay, so these are my conclusions. Hyperparathyroidism is associated with hypertension, myocardial and vascular calcification, cardiac arrhythmias, and left ventricular hypertrophy. Parathyroidectomy is a treatment of choice, and we want to consult the parathyroid surgeon with a high volume of parathyroidectomies. Our third partner is an endocrine surgeon, and he has done hundreds of parathyroid surgeries, so I send all of my patients to him. In patients who are not surgical candidates, regular checkups are important to monitor progress and intervene early in case of cardiovascular events. Thank you for your attention.
Thank you, Dr. Mirza, for such a nice coverage of the parathyroid disorder, its diagnosis, treatment, and complications. And last, we get the lot of informations and diagnosis of the parathyroid disease. Thank you. Any
Thank you.
questions from the audience?
Yes.
For Dr. Mirza? Any question? No question? madam? Such a nice talk, so there is no any questions. Thank you for your presentations. Thank you.
Thank you for inviting me.